step when you go to get your evaluations and approvals for hormones, and it's expensive.
Mm-hmm.
And there are people that will self-medicate for those reasons, in which case finding a professional who can help you and get you on the right medication is really their goal, is to find a professional who will write them prescriptions so they don't have to get it elsewhere.
Right, and there's a part of the WPATH standards of care that actually waives the therapy piece, the gender evaluation, if the patient is at risk of harm. So if you read through the standards, there's a portion that says, you can skip the gender evaluation if the patient is already, either taking hormones that aren't prescription, or you think that they're going to be at risk of harm to themselves if you don't go ahead and proceed with the transition. So there's a little out in the WPATH standards. I think that's sort of provider by provider over who would work with that. Some providers are very strict about having X amount of therapy and X, letters and all this, and other people are more lenient.
Sort of something you mentioned earlier about it sort of shifting to primary care from this, more specialized endocrinology. It was interesting recently when the State Department changed their guidelines for getting a gender change on a passport, that the categories of people that can write your letters, your primary care physician is sort of where they were focusing that on. And historically, I don't think the primary care physician has been very involved in the transition process. But as you pointed out, I think that's changing. I think it's becoming more and more common, whether it's a primary care or an OBGYN, which I think was also in the list. It was primary care, OBGYN, endocrinologist.
Yeah.
The gender therapists and such, they seem to be losing favor.
Well, I think that part of the changes in the passport requirements were that you no longer have to have proof of surgery.
Right.
And I think that people are starting to realize that surgery is not accessible for everyone because of cost, and some people don't want it. Some people aren't happy with the outcomes and prefer to just sort of keep what they got. So I think it's nice that it's recognized that the genital surgery isn't the end point of your gender identity or your gender transition. So that's definitely changing. And Massachusetts changed its driver's license or state identification criteria as well, so that you need a letter from a therapist or a healthcare provider stating that you are this gender and you're under treatment for that. So they also don't have a surgery requirement.
Yeah, Connecticut's is the same way as far as the state ID goes, driver's license. Therapist letter suffices.
Yeah, and it's good because even for people that would like surgery, it can be years and years and years before it's accessible. And for female to male folks, they might have top surgery, which is the double mastectomy with chest reconstruction, but bottom surgery is not something that people get all the time.
Yeah, so it's not as nearly as well perfected, and the various different procedures don't result necessarily in equal output.
It's much more dangerous too.
It's my understanding is that the risk of negative side effects or negative outcomes is greater with the female to male procedures, genital procedures. So like you were saying, they haven't really perfected any specific techniques yet.
Well, that's one of our female to male members likes to use the phrase that it's easier to dig a hole than build a pole.
Yes, you can't create erectile tissue, to the best of my knowledge.
It's not
but
yet.
You can take it away.
But you can take it away. So we certainly we've been in contact and we have female to male members, and it is not. This is purely empirical, but it doesn't seem to be as big a priority, and I sort of understand why. but the MJF, the male to female surgery is very well perfected.
But still very expensive.
Very expensive, yeah.
The base model's a new car. If you want to get fancy, it's a luxury car.
Yeah. And insurance is not there, so it's a lot of out-of-pocket expenses, certainly. It's very cool. It's a very cool surgery. I'm not going to.
I'll have you know, I got to bring up degloving at work today.
Ugh.
Oh.
It's not a fun topic. Or maybe it is a fun topic.
A lot of people get very squeamish about that.
Well, in general medical parlance, it just refers to any procedure where there's a large patch of skin detached from tissue.
Yeah. Okay. We talk about these things. Sometimes we do discussion panels and stuff at schools and things, and we wind up talking about these things.
And I have some really great coworkers that let me turn our cubicle into a discussion forum too.
Yeah. But it does make some people rather squeamish. But anyway.
Anyway, we have a few minutes left.
Yeah. So it's it's certainly been a very interesting thing, and it's nice that that there are more physicians getting involved in this, and certainly my primary care physician. I've seen a lot of changes just in the time since I started transitioning. A lot of changes, and my primary care physician was much more involved than most have been in the past. He didn't actually do any procedures or hasn't prescribed hormones or any of that, but he sort of coordinated a lot of the stuff and did all the ancillary requirements and stuff that he kind of took care of. It was really kind of nice to have somebody that sort of knew something about it, and so it's nice that you're there.
Let me ask you maybe an odd question. Considering that you see a large number of GLBT people and a large number of non-GLBT people, or at least so far as they've admitted to you, do you see much difference in the way of medical problems that they deal with? Is there stuff that sort of the GLBT community has to worry about differently than the rest of society?
I think yes and no. I think I see a lot of people with the same problems. Maybe the GLBT community isn't addressing the problems with their providers because they're worried about going in or worried about judgment. So a lot of the base health problems are the same, which would be diabetes, high blood pressure, cholesterol, heart attack risk, that kind of thing. I think for the LGBT community specifically, HIV risk is an issue that should be addressed with providers, depending on people's sexual practices. And then with transgender health specifically, there's the hormone therapy monitoring and sort of like watching for effects kind of thing that we see. But I would say overall, the patients that I treat, aside from specific issues regarding hormone therapy, the medical problems tend to be very similar.
So more the same than
so
different.
Yeah, medically speaking, we're more alike than different.
Yeah.
But I know that the question about the HIV testing, because we've had a number of discussions on this show with people in the community working with HIV and AIDS. Is it, on my curiosity, is it a big deal to get the HIV test done when you send out the blood panels? Or? No,
not in my community. It's actually now recommended that everybody be screened for HIV, every adult be screened for HIV. So we offer it routinely for all of our patients, and we offer it yearly. More frequently if people are having higher risk behaviors,
that's
less
good.
frequently if they're having
because I mean that seems to be one of the things that I know we have like a minute left, is why we don't just make it part of the standard blood panel to test for HIV.
Yeah.
It should be.
Completely out of time.
All right, Reggie.
Thank you
so much.
Thank you so
Yes,
much.
no
Come back
problem.
and see us again, please.
We will.
It was really wonderful having you. And thank you everybody for watching, and join us again next week.